I'll be talking on reducing complications arising from egg collection and embryo transfers. I would like to divide my talk to two parts. First part will be about the oocyte collection, and then will be the embryo transfer. Ultrasound-guided transvaginal route is the commonest approach. Easy to learn, relatively less invasive, overall a safe procedure. But we shouldn't underestimate its risk. Most of the time it's underreported because most of us prefer the other outcomes, which are, in terms of pregnancy, live births, which are more important to us. However, risk also should be clearly documented. The first way to reduce risk is to identify them first. To reduce a complication, we have to identify the patients at risk. So we have to stratify the patients according to their risk factors, like those increase in risk of developing OHSS, like high image, high intrafollicle count, young, PCOS. Then we should start a lower dose. And those with medical illnesses, like thyroid, diabetes, bleeding disorders, and cardiac diseases, then we should optimize them first with a multidisciplinary team first, then proceed the treatment. And those with previous history of surgeries like laparotomies, cystectomies, ruptured appendix, they can have a lot of dense adhesions in their peritoneal cavity, and some of the ovaries are adhered very high up the uterus. And patients who have had cervical surgeries too, they can have stenosis, and that will make our transfer very difficult. So it's very important for us to know the anatomy and whatever is deviated in the patient. Pre-operatively, before we start, let's go back to basics. Routine assessments, blood counts, blood sugars, kidney renal functions, and if necessary, coagulation screen. Patients above the age of 40 do an ECG, and in some cases, an anesthetist should assess the patient prior to the procedure. As for surgeons, all of us powder-free gloves, sterile gloves, and OT should have well-maintained equipment, and all should be sterile as far as possible. I would like to go through this study. This study was very interesting as the number of oocyte retrievals was large. 23,827 oocyte retrievals were done. This comes from Italy. The complication rate was 0.76%. If you can see here, hemoperitoneum occurred in 0.23% of cases. Out of that, 18 had to undergo laparoscopy. 1 had to undergo laparotomy. This case, the patient had a laceration in the iliac vein. The others were mainly bleeding from the multiple corpus luteum. Then they had some pain, vaginal bleeding, which required vaginal suturing, bladder lesions, which just needed observation and catheterization. Infection was there were 10 patients. Most of them needed antibiotic therapy, 2 laparoscopy, 1 laparotomy. And the next part of it, we always talk about surgeon-related complication. How about the anesthetic? They had 14 cases which had complications. Some had circulatory shocks, nausea, atrial fibrillation, cardiorespiratory insufficiency, and confusion. Most of them recovered with just plain normal observation. In that study, their risk factors were younger patients, thinner, low BMI, longer operative time, higher number of oocyte retrieves because there were multiple punctures, and the surgeon's experience. For them, the experienced surgeons are the ones who have had 250 oocyte retrievals done before. But what is not significant was duration of infertility. Now, coming to the complications per se. In general, vaginal bleeding is the commonest problem that we face. Some studies are putting up to 8.6% incidence. The main causes are multiple punctures, like in patients who have too many egg follicles, and those patients tend to bleed more. Poor technique, excessive movements. This will cause lacerations on the vagina and the vaginal wall, and also on the ovary. The usual way of treating these patients would be putting a compression, keeping it there for a minute or two, or tamponade if you need to. And very rarely you have to suture the puncture sites. Another way to reduce bleeding is to use fine oocyte retrieval needles. I've started to use this needle called Sense from Vitrolife. The body is 17 gauge and the needle tip is 20. So I found the bleeding to be much lesser. Probably you should try the smaller needles. Next, the bleeding source can be due to the ovarian vein, iliac or sacral vessels, or the follicle punctures itself. ovarian lacerations due to excessive movements, ruptured endometriomas, and injury to the pelvic vessels like the iliac vessels. Intra-abdominal bleeding can occur in 0.06% to 0.35%. The mainstay of treatment is early hemodynamic monitoring and resuscitation. Blood transfusion may be required, but you may have to do a laparoscopy or laparotomy, just like what I mentioned in the previous study. So how do we prevent it? Firstly, visualize the follicles nicely. Aspirate the follicles without withdrawing the needle from the ovary and avoid multiple vaginal punctures. Gentle manipulation of the needle and proper visualization of needle tip. Don't overshoot the ovary. Use color Dopplers if you are unsure of the blood vessels. So with color Doppler, you can identify the blood vessels clearly. And for those who like to use the double lumen and like to flush, avoid over-distension of the follicles during flushing. And for those patients where you suspect that they may be having some blood disorders, a coagulating screen may be warranted. The others is like what I mentioned, visualization of the pelvic organs should be visualized in both the planes, longitudinal and transverse plane, because even a vessel can look like a follicle. So when you turn the probe around, then you realize that it's a blood vessel. So once you have completed, examine the pelvis to ensure that there's not much of fluid collection inside. The next will be haematomas. It can occur both intraperitoneal and extraperitoneal, and it's secondary from bleeding. You can identify it best by CT scans. The hematoma should be suspected in patients who have worsening lower abdominal pains, anemic symptoms. Then it should be checked and resuscitated adequately. The next risk would be pelvic abscesses, ovarian abscesses, or infected endometriotic cysts. This risk is low, 0.01% to 0.03%. It's due to iatrogenic inoculation of the pectoral cavity with bacterial flora from the vagina. It can also be caused by a direct colonic injury. Some studies have also spoken about fungal organisms which have caused this. So to reduce the risk, identify the patients with endometriotic cysts or patients with a history of laparotomies, because when they have history of laparotomies, they may have lots of adhesions inside, dense adhesion, obliterating the whole anatomy. Avoid endometriotic cysts and the hydrocephalus too. In patients which are higher risk for this to occur, you might want to start them on antibiotics pre-operatively or intra and also post-operative. In patients which are endometriotic cysts, I generally give them pre-operative penicillin-based antibiotics and continue another few more days after the procedure. As for antibiotic protocol, well, there's no consensus. Most of us, most of my colleagues, most of us research that I've gone through a couple of days, most of them prefer cephalosporins or penicillin-based antibiotics. To reduce the risk again, fewest possible vaginal punctures. You may use vaginal disinfectants. However, 1% solution of povidone was associated with a lower pregnancy rate secondary to possible embryotoxic effect of the disinfectants. But rinsing with the saline itself did not increase the risk. What I generally do for these patients at risk, I'll use diluted povidone followed by irrigation with saline. The other thing would be to reduce the risk is to look for the peristaltic bowel on the ultrasound while performing the aspiration. The next common issue that we face would be pain. Severe pain has been seen in 0.7 to 2% of women. And again, it increases the risk with increased number of oocyte retrieve and repeated passage through the vaginal fornices. We should avoid overstimulating our patients. That's the first thing, and that will reduce the problem. Secondly would be you give them painkillers a few hours prior to the procedure, for example, paracetamol, a few hours prior to procedure. And you may, if you're not doing a fresh transfer, you can give them an IV analgesic after the procedure. Next would be torsion. Torsion can occur, the incidence of 0.1%, because the ovary has enlarged 2 or 4 times the normal size, even after aspiration. And this risk further increases with ovarian hyperstimulation syndrome, especially in women who have become pregnant. We had one patient like this a couple of years ago, for which we had to do a laparoscopy and untwist the ovary. And laparoscopic untwisting of the ovary is one method of choice. Most importantly, early surgical intervention relates to reperfusion and preservation of the ovary, especially if performed within 6 hours of torsion. The other rare things which are difficult to identify is the ureteral injury. Dense pelvic adhesions from endometriosis that cause a lot of distortion in anatomy. And you may accidentally injure this organ, and also extrinsic compression from hematomas and abscesses. The third way is that secondary to direct injury with subsequent scarring can also cause ureteral injuries. So this patient will be obstructed. You will come in with severe pelvic pain, flank pain, and fever. Most of these patients can be managed conservatively with a urologist and placement of a stent into the ureter. They have a hematoma or abscess, then it should be drained first. Very likely, the ureteral injuries are much more common, but not reported much because it may have gone unrecognized, and most of them may heal spontaneously. Next, it's the nerve injuries. This may result from the compression due to surrounding hematomas, abscesses, or even direct injury from the needle. Patients present with paresthesis or paresthesia involving the lower extremities or around the groin area. And the way to reduce it is to limit the number of needle punctures is important. The other complications like injury to appendix, when bladder injury. So the way to reduce a bladder injury would be to empty it prior to the procedure to reduce the potential risk. Damage to pelvic organs from the needle cannot be always assessed and may remain undetected in most of the cases. But thankfully, most of them resolve spontaneously. And a lot of times, for example, pain, bleeding, a lot of fluid in the abdominal cavity, you may think it's OHSS, but it's not. So I guess we should not underestimate our OHSS patients. They may be something else. After the procedure, we generally observe the patient for a couple of hours, give them emergency contact numbers, and then the very next day, we call them to find out how they are. If there are any problems, we tell them to come to the accident emergency whenever they have an issue. The other thing to reduce the complication is training. This is the study which I spoke about initially. That this study showed that after 250 procedures per operator, the complication percentage reduced markedly. So that's quite a bit. So I guess proper supervision is required in most in the new trainees. Another study by Goldman, he has mentioned that 20 oocyte retrievals are sufficient for a person to be well trained, and a minority of them may require 50 procedures to achieve the proficiency of an attending physician. I found this article in the internet a few days ago regarding the Pickup CMTM. This is from France. They are doing a study on simulators for oocyte retrievals, but the outcome has not been published yet. The next part of my talk would be about embryo transfers. This is a final and most crucial step in IVF, so we have to have proper technique. So before the embryo transfer, it's important that we inform the patient about the number of embryos she has and advise her regarding the number to be transferred. For example, single embryo transfer is the best, this is what's desirable now to lower the risk for multiple pregnancies and its associated risk. The other thing would be to try our best to push it to day 5. As we know, day 5 embryos are relatively much better. Most centers use the NICE guidelines or a slight modification from it in terms of reducing their multiple births. Women under 37 years of age undergoing their first IVF should have a single embryo transfer. In a second cycle, if she has a top quality embryo, then she should transfer 1. However, we can consider putting 2 if there are no top quality embryos. In the third cycle, no more than 2 embryos will be transferred. Women aged 37 to 39 years of age, in their first and second cycle, they should also have a single embryo transfer if there are 1 or more top quality embryos. However, double embryo transfers if we do not have a top quality embryo. For women above age of 40, then a double embryo transfer should be considered. Now, the benefits regarding a blastocyst transfer. We always get this in our practice. The patients will come and tell us, well, another doctor mentioned day 3 and day 5. So the benefits is better synchronization between the embryo and the endometrial cavity. In this way, we can choose the best embryo and we can put in 1 of these and we can reduce the risk of multiple pregnancy. The other thing before embryo transfer is the mock transfer. Timing. A lot of studies have discussed this issue. where some of them do the mock transfer before the stimulation, some during the second scan of the stimulation, some even after the oocyte retrieval when patients under anesthesia. Most of the time, it all depends on which practice you are comfortable with. We do it on the day of oocyte retrieval. We do a gentle mock transfer. You should document the length, direction, angulation, and to discover difficulties like pinpoint cervix and all. So before the transfer, we prefer to have a slightly bladder, and that way you'll straighten the uterus. Now in UTI, you'll use a speculum to visualize the cervix. We clean the cervix with a sterile gauze to remove the mucus. When there's a lot of mucus, then you will want to use a 1 cc syringe to aspirate the mucus out and clear the cervix. The other thing would be the choice of catheters. A soft, malleable, echo-dense tip, okay, will be the best option because that will be atraumatic. Avoid trauma to the cervical canal endometrium. And in that way, with soft catheters too, you can avoid uterine contractions. Use ultrasound guidance for proper placement and avoid deep placement of the embryo because that will cause bleeding, contractions, and if you release the embryo high up, then there's a risk of ectopic pregnancies too. And the ejection should be slowly applying pressure on the plunger. And when withdrawing the catheter, we should maintain pressure on the plunger while slowly withdrawing catheter to avoid the negative pressure. We should do this procedure as smooth and as fast as possible. During embryo transfers, some clinicians prefer to use tocolytics, sedations, or anesthesia, especially those patients with severe vaginismus. Hypnosis and acupuncture too have been described. Now, in patients with difficult transfer, especially those with tight or closed cervix, pinpoint, distorted cavity, or when those with previous surgeries, extra procedures may be required. For example, of valsalum to straighten the angle, but that's not desirable as that will cause a lot of uterine contractions and even pain. You can use a firmer catheter with stylet, and times you might have to give it some form of sedation for her to relax. The others would be to abandon the procedure, like freezing and transfer in subsequent cycle. In patients where you have had a difficult transfer, we might want to do a cervical dilatation to correct the stenosis. Some studies have spoken about Lemuria tents and hygroscopic rods to slowly dilate the cervical canal. But some have spoken about infection that can cause if you leave it in there too long. The others will be transvaginal ultrasound probes, which can be used at the same time you do your embryo transfer. We do it abdominally. The next would be your transmyometrial embryo transfer or tobacco catheter. This is said to cause a lot of bleeding and myometrial contractions. I've not had experience of using it. I found this study from India, difficult embryo transfer and systemic review. They looked at reviews from 1980 to 2017. The majority of cases had cervical stenosis, which required cervical dilatation. Higher pregnancy rates were seen if you do the dilatation minimum 3 weeks before the embryo transfer. Now, after embryo transfer, it's important to check the catheter for retained embryos. We prefer to check the inner and the outer catheter too, because sometimes as you withdraw the inner catheter, some of the embryos may follow the inner catheter and will be lodged in the outer catheter. They found retransfer immediately. There's a study by Mansour et al. He said that to put in a gentle pressure on the cervix with closed speculum after the transfer to decrease the embryo expulsion. The next controversial thing would be bed rest. There's no statistically significant finding to say that bed rest is essential after an embryo transfer. Just allow the patient to bed rest just a few hours after the procedure or even after inserting the vaginal pessaries, and that's about it. There are a lot of medications that we give patients after embryo transfer: progesterones, oral, vaginal injections, estrogen, aspirin, Viagra, antibiotics. There's no really standard protocol. A lot of physicians prefer to have their own recipes to give the patient after the procedure. But most importantly, progesterones are necessary. So in short, IVF is a wonderful option for many patients, but it's important that we explain to them then all the possible complications, and they should understand the risk and the benefit that the procedures have. Thank you.